Hello, my name is Dr. Jacob Curtis. I'm a board-certified family physician at Grand Peaks Medical in Rexburg and St. Anthony, Idaho. I also have additional advanced training in emergency medicine and obstetrics. Today's educational presentation that our organization is offering is on what's referred to as advanced directives and end-of-life decisions. Before you turn this off, thinking, I'm 20 years old, why do I need to watch this? There might be some information in the next 10 minutes that can benefit you and your loved ones. And so I invite you to perhaps seek through this resource or others some additional information. This educational presentation has come about as a request from our good nurses who work at the hospitals, especially in both the cancer wards, the ICU, and the emergency department. One of the tragedies that we often face in life is first-line responders and frontline workers in emergency departments, and oftentimes even in primary care offices, are when you have a patient who is actively dying from a life-threatening process, especially those who are in their early years and haven't thought in detail or articulated the wishes of what they would like to do when their end of life comes. And so the purpose of this is to kind of discuss that, demystify it, and hopefully encourage us to think about that and discuss it and write it down with our loved ones. So with that, we'll begin. This has been a grant possible by the hospice organization. These are free slides for all, and there's some resources within that will help you to save some expensive attorney fees. Nothing against our attorney friends out there. So our goals in the next 10 minutes are to discuss advanced directives and end-of-life care decisions, learn the different types of advanced directives, talk about the pros and cons of having an advanced directive, and also discuss and identify additional resources that can help us in our decision-making processes. The first question we might ask ourselves is, do we have a plan? Some even liken it to a roadmap. My family likes to travel pre-COVID pandemic, and very rarely do we head out without a specific plan of where we plan on going to. I have a friend who does, and they have adventurous stories to tell. But most of us, we have a plan of what we're going to do. But sadly, most Americans don't have a plan for their end-of-life care decision-making processes. Why do we need it? The biggest reason is so that your wishes are known when you're not able to articulate them yourself. And so situations that I just saw yesterday, a woman with metastatic cancer came into my emergency department in her late 50s with severe COVID. She's on a high-flow oxygen mask. We're contemplating on whether or not she needed to be intubated, trying to gently and cautiously determine for her family, and they just didn't know. And it's such a sad and stressful situation, and because those wishes had not been, I guess, identified and articulated, it makes it tough for her to be able to communicate that when she's not in a position to do so. Other situations that we might see is severe heart attacks, strokes, traumatic injuries, specifically car accidents and things of that nature. It's important to know some people get worried that what if I wrote something down and I changed my mind? As long as you're still conscious and able to declare that, then your wishes live or in person always supersede what you've articulated in the past. And so you don't need to be worried about, we're not going to save you because you said here 10 years ago that you didn't want resuscitation. So your conscious decision always takes precedent of what you've written down before. This can happen to anyone at any age, but we especially focus in on those who are at increased risk of passing away someday in the last 2 to 3 decades of life. So usually once we become elderly or of that retiring age around 60, 65, this is a really good thing to think about and to have. And really, it can be a gift to your loved ones. It's so sad and so stressful for them to have to make difficult decisions during stressful times. And so it really helps to take that burden off of them. It's interesting to note that most Americans, approximately 9 out of 10, state that when surveyed, they feel comfortable discussing end-of-life issues and death and dying. Yet research has found that only 4 out of those 10 actually have a living will. So what are advanced directives? Generally speaking, it's a written statement that goes over your preferences, your wishes, choices that you'd want your loved ones to make in your behalf regarding end-of-life care decision makings. And we'll cover this in forthcoming slides. And so an advanced directive is a roadmap or a tool that can help guide you through and communicate those choices. Advanced directives, in contrast, are written instructions about future medical care and are only used if you're seriously ill and or unable to speak for yourself, is already addressed. There's 2 parts of an advanced directive. There's the living will component, and there's also identification of a medical, also known as a healthcare power of attorney. We'll cover that. So the living will is one part of an advance directive. It's a legal document. It is legally binding, but doesn't necessarily require an attorney to sign off on that or a notary public. It's a legal document that identifies your wishes about medical treatment. You choose what you do want and what you would not want. A medical power of attorney, this is a document referring to an individual, oftentimes a close family member. For elderly, it's usually one of their adult children who they perhaps have more frequent contact with, maybe somebody who's living close, but not necessarily. It's a person that you've identified and given authority to speak in your behalf, again, only if you're unable to communicate those wishes for yourself. Again, during times of a severe stroke, severe heart attack, trauma, or as we're seeing during this pandemic year, a lot of people with severe hypoxia and respiratory distress. This may also be called a healthcare proxy, a healthcare surrogate, or a durable power of attorney. It's important to realize the following are advantages to having an advance directive. You are in charge, you're in control. Nobody's having to guesstimate and do things that you would not want to have done in your behalf. So it gives you the power and control over what happens with you and your body and future decision-making processes. It's a document that can be changed anytime. You do not need an attorney for this. The documents can help you express your wishes. Forms are available. I really like this caringinfo.org. A lot of more detailed information concerning this presentation, as well as a document that can print out. But also if you Google in Advanced Directive Living Will, you'll see some people who want to collect a fee, but you'll see some free PDFs that can be accessed as well. And again, I would just wear my ER physician hat for a moment and say, do I need to see a notary public or a lawyer signing off on these when families talk about wishes? I don't. And honestly, when I have a tough decision, we're just in the moment and in that crunch time where you ask, has your loved one ever expressed, do they have a living will, advanced directive power of attorney? And sometimes they'll say, I'm the power of attorney. What have they declared? Sometimes they're like, well, let me find that paper. I'm like, beyond the paper, what's it say? And they say, Dad would not want to be resuscitated if his heart and lungs stop. And then we honor that. Really, the only legal issues are if you have family members who are in conflict of what should be done. Advanced directives may not, these are the disadvantages, may not be available at the time of need. And so what does that mean? Again, I don't really care as an ER doc about the piece of paper. I just want to know that it's been clearly communicated. Sometimes our elderly loved ones have filled it out but not communicated, kind of kept it in secret and in private, and it doesn't really help your family members. So kind of articulating those wishes and sharing it with those so that they're familiar with that. And then when you do updates, the same thing. It may not be readily available in the patient's chart. So if you do take the time to do it, which we're strongly encouraging, please provide a copy to your primary care office and they can have it in your healthcare record. Living wills may not be specific enough. We're going to talk about that in one of the last slides. It may be overridden by a treating physician. Now that's kind of frightening and concerning. Let me give an example. If I have somebody, and I've seen this often through my career as being an ER doc for 15 years, we have a lot of individuals, young and old, who struggle with depression, anxiety, and suicidal ideation. I remember being a young doc and a young man had tried to end his life, unbuttoned his shirt. He had overdosed on some opiates, and we're getting ready to start the resuscitation process, and he had taken a marker and written on his chest, DNR. Obviously, in that situation, because of his mental illness, he's not able to make healthy decisions for himself, and so that DNR directive was not followed. And happy to say that he was safe from that suicidal encounter and went on to have a much better life. That I know of. Medical terms, end of care decision making. These are the things that should be discussed and on the different documents that can access. So life-sustaining treatment, specifically articulating if you had a chronic illness, would you want to be transfused? Some have religious beliefs that would go against the idea of transfusion. Others may require antibiotics. Others may require electroconvulsive therapy in English, shocking their heart back into normal rhythm. It's important to get that clarified. Some people, unfortunately, will lose their ability to make decisions for themselves. They're on a ventilator like we're seeing during this COVID pandemic. They may have had a stroke, been in a severe car accident, and, quote, brain dead. The family is left with a very challenging decision when these wishes are not articulated to try and decide whether mom, dad, brother, sister, son would want to be on a feeding tube and artificially kept alive, even though brain activity is minimal, but the heart and lungs are still working. So clarifying those types of things. Another thing, when somebody's in a comatose state, they may not even be intubated, but do we start an IV to provide hydration to prevent dehydration. Those are challenging decisions to make. Let me clarify the difference between CPR and DNR. Cardiopulmonary resuscitation suggests that the heart has either stopped or is headed in a direction of soon to be stopping based on certain abnormal and lethal rhythms. Pulmonary resuscitation refers to the lungs, much like a case I saw yesterday. A woman was found to have an oxygen level less than 50% at home, and then came in and was on a very high flow mask device, and the next step was intubation. And it hadn't been clarified whether or not she would want to be intubated. And so we spent some time trying to clarify that in the heat of the moment. And so that's pulmonary resuscitation. Again, not necessarily denoting that somebody's not breathing. And that's where DNR comes in. So DNR usually refers to the concept of if the heart and lungs have stopped, what do we want to restart them? Most people will say, well, sure, but it's important to know the effectiveness of CPR goes down dramatically, especially after the age of 65, even in young people. If the heart and lungs have been stopped for more than 5 minutes, the likelihood of brain damage is significant and severe. And so oftentimes there are worse things sometimes than dying. It's living with chronic conditions that are severely debilitating, many medical authorities would attest. And so clarifying before you get in that situation. Something that I often hear from the elderly is when I'm clarifying this, when somebody has a severe disease in the ER, getting ready to admit them to the hospital, like, would you want to have your heart and lungs stopped? Well, if you can save me and if I'll do okay, we don't have crystal balls, and so we can't predict, and so that individual remains a full code. Palliative care refers to somebody who may have a chronic and potentially life-threatening illness, such as cancer, but still wants to go through chemotherapy. Hospice is when they realize that the disease state, unfortunately, has a high probability of ending their life in the next 6 months, and it allows more resources, according to their insurance provision, that would make them comfortable and the loved ones comfortable in the last 6 months of life and can be renewed. I know these are serious and sober topics, and sometimes can be difficult to discuss, but so important. It can be done in a lighthearted manner, but just the peace of mind it provides is profound. And so I encourage you right now, when this video is being recorded, we're in a holiday season. Historically, in a non-pandemic year, families are getting together and live or by Zoom calls, and it would be a good time to save a few months to, hey, what would you want done in these situations? And maybe somebody's taken some notes and can put that into plan. It will save you and your loved ones a lot of grief, stress, and heartache when the decision really becomes necessary to make. Thank you for your time.